All right, let's dive into a tale of two very different bellies. We're going to tackle two pediatric GI emergencies that, let's be honest, can look a little similar and get confusing on exams. But our goal here isn't to just memorize symptoms. We want to get to the why. We're going to visually map out exactly what's happening inside the body step by step so you can literally see the whole process in your head. Let's get into it. So this is the big question, right? This is our clinical puzzle. You've got two tiny patients, both are in distress, but they are telling you two completely different stories. One baby is throwing up with incredible force, while the other's major symptom is showing up in their diaper. The secret to telling them apart and really crushing their exam questions is all about understanding two totally different kinds of blockages. One is a muscle problem, and the other is a blood supply problem. So let's crack open the first case file. First up, case file number 1. And for this one, I want you to picture a blocked gate. That's the key visual here. The diagnosis is hypertrophic pyloric stenosis, and the entire problem boils down to a physical, mechanical blockage right at the exit door of the stomach. Okay, so here's our main character, the pylorus. Up top, you see a normal one. It's basically a muscular gate that opens and shuts, letting food go from the stomach into the small intestine. Simple enough. But look at the bottom image. In our first case, this muscle has gone into overdrive. It's overgrown, it's hypertrophied. It has become so big and so tight that it's essentially clamped shut. So this whole condition is about that muscle hypertrophy. The circular muscles of the pylorus just get thicker and thicker. And here's a really important point. This isn't because of swelling or an infection. Nope, it's a structural problem. The muscle itself just grows so big that the tunnel out of the stomach becomes incredibly narrow, almost sealed off. This cascade right here, this shows you exactly how we get to that crazy vomiting. First, the pyloric muscle thickens up, which, as we saw, narrows that exit gate. So when the baby drinks milk, it hits a roadblock. It has nowhere to go. So what happens? Pressure. A ton of pressure builds up behind that blockage. The stomach, trying to do its job, contracts with all its might to force the milk through. But it can't. There's only one way out, and that's back up. And that's what causes that classic forceful projectile vomiting. It's really just pure physics.
Okay, exam alert. This is a huge must-know point. The vomit is non-bilious. That means it's not green or yellow. Now, why is that? It's simple anatomy. The blockage is at the pylorus, which is located before the spot in the duodenum where the bile duct dumps in bile. That milk never, ever makes it far enough down the GI tract to mix with bile. If you see non-bilious projectile vomiting on an exam, this should be screaming in your head. So let's put all the clues together. When you're assessing this baby, you might actually be able to feel that thickened muscle. It feels like a little olive in their abdomen. You might even see the stomach contracting, these visible waves moving across their belly. And think about it. The baby is starving. They just vomited everything, so of course they're hungry and irritable. All of this vomiting leads to dehydration and, critically, metabolic alkalosis from losing all that stomach acid. Every single sign points right back to that blocked gate. All right, let's switch gears completely. Now we're on to our second case, which has a totally different mechanism. So forget the blocked gate. Now I want you to picture a collapsing tunnel. We're talking about intussusception. Intussusception is just a fancy word for when one piece of the intestine slides, or telescopes, into the part right next to it. You know, like one of those old-school collapsible telescopes. You can see it here perfectly. That upper part of the bowel has just pushed its way right inside the lower part. Now, this is not just a simple blockage. This is a vascular emergency, and it's a huge deal. As that bowel telescopes, it drags its own blood supply, the mesentery, right in there with it. And those blood vessels get trapped and squeezed. First, the veins get compressed so blood can't get out. This causes a massive backup, leading to swelling and engorgement. And that swelling then puts so much pressure on the arteries that it cuts off blood flow in. Without blood, that bowel tissue starts to die. That's ischemia. And that dying ischemic tissue starts to break down, producing a nasty mix of mucus and blood. And that process leads us directly to this. This is the hallmark, the pathognomonic sign of intussusception, current jelly stools. We're not talking about a little bit of blood here. This is a thick, gelatinous mess of blood and mucus that comes directly from that dying bowel wall. When you see this phrase on an exam, your brain should immediately just yell, intussusception!
The other clues also point straight to this ischemic process. The pain is sudden, it's severe, and it comes in these waves. That's the bowel spasming. The child will instinctively pull their knees to their chest to try and relieve that intense pressure. You might be able to feel a sausage-shaped mass. That's literally the telescoped bowel. And the vomit? Because this blockage is much further down the intestine, it's often stained with bile. and can even become fecal if the obstruction gets really bad. Okay, so we've walked through two very distinct pathways, right? One is a tight muscle, the other is a full-blown vascular crisis. Now let's put them side by side. This is how we're going to lock in these concepts for your exams and, more importantly, for your clinical practice. This table right here, this is your high-yield cheat sheet. Let's run through it. For pathophysiology, it's an outlet obstruction versus a telescoping bowel. For vomit, it's projectile and non-bilious versus bile-stained. For stool, it's normal or constipated versus that classic current jelly. For pain, it's irritability from pure hunger versus that severe colochic pain from ischemia. And finally, the mass you might feel. A small, firm olive versus a longer, sausage-shaped mass. If you can burn this table into your brain, you will be able to tell these two apart every single time. So what's the bottom line? What's the ultimate danger of each of these conditions? With pyloric stenosis, the primary life threat is the metabolic chaos from all that vomiting. Severe dehydration and metabolic alkalosis from losing all that stomach acid. But for intussusception, the threat is a dead bowel. That loss of blood supply leads to tissue death, perforation, peritonitis, and sepsis. The first one is a fluid and electrolyte emergency. The second is a time-sensitive surgical emergency. And this all brings us to the most important question. Now that you can truly visualize the why behind everything, how does that change what you do? For that baby with pyloric stenosis, your absolute priority is fixing their fluids and electrolytes before they can safely go to surgery. But for the baby with intussusception, your priority is recognizing the signs of shock and perforation and getting them ready for an immediate procedure to save their bowel. See? Understanding the why doesn't just help you pass an exam, it makes you a safer, better clinician at the bedside.